Hi, good evening. I'm David Levine. I'm co-chair of Science Writers in New York. Dr. Moore, can you turn your video and microphone on?
Good evening.
So I want to thank Joe Bonner, as usual, my co-chair at SWINY, for producing this and making us look good. So my guest is Dr. John Moore. He's an American virologist, a professor, known for his research on HIV and AIDS. He's been doing this a long time. He previously worked at the Aaron Diamond AIDS Research Center. He's a tenured professor of microbiology and immunology at Weill Cornell Medicine in New York. He received his BA, his MA, his PhD degree from Cambridge University, and he joined Weill Cornell in 2000. So he's gotten numerous NIH grants, did a lot of publications, and so we're very happy to have you spend an hour with us today. So we've all heard of the Pfizer and Moderna vaccine, but you're in a trial for a different vaccine. I wonder if you could tell us a little bit about that.
Sure. Yeah, but before I start, I just wanted to say something about science writers and journalists in this pandemic. I think the quality of the science reporting has been absolutely fantastic. And I know a lot of my science colleagues think the same thing. We learn a lot by reading what you guys write in newspapers and the more specialist media outlets. There's a lot of stuff in there that we go, yeah, I need to read up about that. So you all collectively done an amazing job. So yeah, take credit where it's due on that.
Yeah, thank you.
Vaccines. So I joined the Novavax phase 3 trial at the site at the Weill Cornell Institute here about a couple of weeks ago. My second dose of vaccine or placebo is next Tuesday. So I have a 2 in 3 chance of getting an active vaccine, 1 in 3 of getting the placebo. That's a protein-based vaccine in an adjuvant, so it's different class than the approved mRNA vaccines. But like all of the leading coronavirus vaccines, they all have the S protein, the spike protein as their active component. So they're all different designs that converge on the same point, inducing antibodies and T-cell responses to the coronavirus spike protein.
So for those listening, if you have a question, please put them in the Q&A box. Don't put them in the chat box, and we will get to all your questions. I promise that. So one thing when we spoke, last week, you said that the vaccines were not that hard to figure out, that the technology was kind of known, and that the target was well known. And I think that surprised me. And but we never had messenger RNA. So why don't you first explain what messenger RNA is, how it works, and what's targeting it?
Well, messenger RNA is a tool to deliver the spike protein into the body. As I just said, all of the vaccines that are all the leading ones, and most of the ones that are in earlier stage development, are based on presenting the viral spike protein. And that is the entity on the virus that induces neutralizing antibodies. But you can do this in different ways. You can deliver it as a protein, so you make the protein in cell culture and purify it, and then mix it with an adjuvant and inject it into your arm. That's the Novavax vaccine that I'm in the trial of. Or you can put the spike protein genetic material into messenger RNA, which is, you can think of it as like DNA, but it's importantly different, but it's still a genetic strand. And that genetic strand is packaged in a lipid, fat protein sphere to protect it. And then the lipid mRNA complex is what is injected into your arm. And then once those little balls of fat with RNA in them are taken up into cells, and the RNA is converted into protein, and the protein, the spike protein, is then what induces antibodies. And there's also a design based on adenovirus vectors. These are essentially crippled viruses, common cold viruses, that have been engineered to express the spike protein, and you get these injected into you, and the viruses enter the host cells, some host cells, small number of host cells, and within those cells, they produce spike proteins. So again, it's the spike proteins that are delivered. You can think of all of these as transportation devices, trains and boats and planes, but they're all designed to get you to point B as quickly as possible. So, as I say, convergent evolution on getting the spike protein presented. So why do we have a vaccine that was developed, vaccines that were approved within a year, which frankly nobody expected? I mean, if you'd asked any of us in March last year, would we have an approved vaccine by December, we'd have just laughed and gone, yeah, what are you smoking? But it was possible. And the reason it was possible is that pre-existing technologies were repurposed. So you didn't have to invent the technologies. We didn't have to, invent the car from nowhere. We had the pre-assembled pieces, and we just needed to adjust the composition of them. So yeah, mRNAs are the newest, but the technology goes back a decade. It's been thoroughly tested in animals. It's been in human trials for other pathogens. You just won't read much about them because they're low profile. A lot of vaccine trials take place at early stages, but they're not high profile. They're not read about. So existing designs could be adjusted for the SARS-CoV-2 coronavirus sequence. And that's true of the protein vaccines. The adenovirus vaccines, exactly the same. They existed. You could put the right coronavirus composition in them. The adenovirus vectors are in HIV vaccine trials. I mean, most of these designs spun off HIV vaccine research, which I've been beating my head against the wall for the last 30 years doing. So again, it's pre-existing technology. It's not a massive reinvention of the wheel, but it's still been a phenomenally quick process.
And why has it been successful against the coronavirus and not HIV?
Because the coronavirus is an easier virus to vaccinate against, is the trivial but correct answer. HIV has its own unique problems, and where do we start? But the first one is that HIV mutates at an incredibly fast rate compared to coronavirus. Now, I mean, we'll get to talk about coronavirus variants. They're starting to become a thing now after a year. Well, that's not strictly true. They've been around all throughout. But with HIV, the kind of variants that you're seeing with coronavirus, they happen every day. And influenza is another RNA virus that is somewhat in between. It also is very variable. Not as bad as HIV, but a lot less than coronavirus. So variation is a huge problem, and it's less of a problem for coronaviruses, fortunately. Also, coronavirus spike proteins have a relatively easy target on them. They have a region that sticks out like a sore thumb, and antibodies glom onto that, and that takes out the virus. Well, the same region of HIV spike protein just isn't out there. It's like buried in the hand. If that's the sore thumb on the coronavirus, that's what it's like in HIV. So you've got to be a lot more difficult to get at it. It's a lot more difficult to get at it, and we have to be a hell of a lot cleverer, and we haven't managed it yet. So they're the simple answers, and it's not for want of trying, and it's not even for want of funding. It's just a much, much more difficult problem.
Okay, so we've had a lot of cliches about this has been an unprecedented year in a lot of ways, but now every time I hear about vaccines, they say we have to get vaccines in the arms of people. And to date, there have been close to 38 million vaccines distributed, but only 17.5 million administered. I know that President Biden has said he wants to get 100 million shots in the arms of people in 100 days. Is that a realistic goal? Is that something we can do? Yes, today, 1 million people were vaccinated.
Well, now we have better leadership, or we actually have leadership at national level.
Okay.
That will help. It takes time. There are teething troubles. There are kinks in the system that need to be worked out. If you're going to do 100 million of anything, you're in a situation of, well, what could possibly go wrong? I mean, it's not easy to do anything on that kind of scale. So you have to expect teething troubles. Mm-hmm. It's just, it's just difficult to do these things. But you know, a lot of it is organization. The states are underfunded. It's not been ideal to leave states to do all their own thing. Central direction would have helped and wasn't there. There are, you know, local issues like, I mean, friends in New York City tell me that seniors without savvy computer skills are finding it hard to log on to New York City and state websites, to navigate the system, to register, to get the vaccine. You know, I mean, I find web-based forms difficult enough, damn it. I kick them over to my assistant as often as possible. And, you know, if I was 25 years older and had a lousy internet connection and a brick of a phone, what would I be doing? It's not an easy system to navigate. So these are fixable problems. But what we don't want to see, and this I speak for most virologists and immunologists that I'm in touch with, we don't want to see a large gap between the first and second doses. You know, some wiggle room is fine. The gap is 3 weeks for Pfizer, 4 weeks for Moderna. That's a distinction without a difference, frankly. But, you know, 5 weeks won't make much of a difference, but we don't want to see a lot of people half vaccinated. And so all the efforts to get vaccine in arms have got to be coupled to get both vaccine doses in your arms as quickly as possible.
Well, I just got my first dose today, so I hope you're right that I can get it in 3 weeks.
Good for you. And you're clearly, you know, looking all right, so everything's gone fine.
So far, yes.
Yeah, I had zero reaction to my Moderna dose, which may mean either, my Novavax dose, which could be a placebo, or it could be that I have the innate immune system of an amoeba. I mean, I don't know. We'll have to wait and see.
Okay. What made you decide to try that?
Well, 3 reasons really. One, I'm not quite old enough to be eligible for the mRNA vaccines. Although I work in the medical school, you know, my biggest risk is a computer virus, not a real one. I don't mingle with patients. I don't do stupid things. I don't have a huge risk. So I'm not eligible for the mRNA vaccine. My group's HIV vaccine projects over the years have been based on recombinant proteins, which is the same as Novavax's design. So I know the design. I know all about, you know, the structure, and I just know the system. And although it's imperfect to judge across different scientific publications in this area, most people, and certainly including me, think the antibody response to the Novavax vaccine is the strongest of them all. So, you know, it seemed like, well, why not?
Okay. So I'll get to some, let's get to some questions from the audience. So how can we speak about a particular variant when there's probably more than one so-called variant around? And when we are in the United States, have only sequenced 50,000 coronaviruses. So what does that mean? I'm not sure how the two tie in. Maybe you can explain that.
Well, yes. And I mentioned how coronaviruses are not as variable as HIV, for example. But you put an RNA virus into 100 million people and you give it a year, you're going to get variants. So they're around. The question is, how well are they detected? And, you know, I'm British by birth. You can probably tell by my accent. The Brits have not done a stellar job on the coronavirus pandemic, both scientifically and politically. But one of the things they've done better than anyone is surveillance of genetic variants. They've got a really good system. And there was an excellent article from Ben Muller in the New York Times about this last Sunday. So the Brits have done a great job. The rest of us, not so much. So we don't have in place a good genetic surveillance tracking program. So there are going to be a lot of variants around that we haven't seen. Well, variants that are more transmissible are now being seen. And this is not new. The first example of this goes back to last March or April, when most of the initial epidemic in the USA, particularly in New York, was caused by something which we commonly call the Wuhan strain, because that's where it originated. But then a variant which we call D614G, it's our terminology, arose probably in Europe, and the next wave of infections, including a lot of New Yorkers, involved the D614G strain, and it was more infectious, it was more transmissible. So over time, it became the dominant virus. And until recently, that has been the dominant virus worldwide. Now, that's known not to be any differently sensitive to vaccines. So, it's more transmissible, but it's not vaccine resistant. And then in the UK, around August, September, October or so, a new virus started to emerge that is also more transmissible. This is shorthand term, is commonly called the UK variant. The official name is, well, B1.1.7. We just call it B117. And that's now been found in the States, it's been found in Europe, and it is again more transmissible. So just, 50%, 70%. So it's more likely to be spread between people. But it is again not vaccine resistant. It's recently been checked. We're pretty confident about that. But then there's this South African variant, which has a pretty complicated name. It's N501S.V2. So we're still going to call it the South African variant until these things get pronounceable names. N501Y.V2, sorry. So that one is more problematic because that's got a lot of sequence changes that affect its reactivity with antibodies. And papers came out this week that indicates that it's going to have some resistance to vaccines. Now, before we freak out about that, the word is some, and we don't know how much, and it may in practice not matter. It may not be a significant reduction in vaccine efficacy. But we sure as hell don't want this virus spreading here if we can avoid it, because it's more transmissible and it may have some vaccine resistance issues. But again, it looks like not at the level that are going to, cause a mass freak out.
So someone asked, Moderna and Pfizer, if they're kept above, okay, they can spoil. And the question was about 57 people were inoculated by accident with a vial that was too warm. Are these people being followed, and what's been observed so far?
Was that the incident where some person in the middle of state in the middle of the USA deliberately took some?
Yeah, I believe so. Yes.
Yeah. Well, nothing bad's going to happen to them. I mean, the vaccine will spoil. It'll just the components will disintegrate and get cleared by the liver within minutes. I mean, it's not going to be a big deal. I'm sure they're being followed because it would be appropriate to do it, but I wouldn't be concerned if I was one of them.
Okay. Does the warp speed model mean that future vaccine development will be cut down to 12 to 18 months, or will the multi-year model for approval stay in place?
Well, it's money. It was appropriate to put hundreds of millions to billions of, well, billions of dollars into warp speed, considering the nature of the pandemic. You could adopt that model for other emerging pathogens if they're on the same global, if they're on the same threat scale. But I can't imagine if you were developing a vaccine for the common cold, for example, I don't think it would be done like that. I mean, the one really good decision that Warp Speed made was to pre-produce large stocks of these vaccines before they had been approved. So normally, if you're a company doing this, you would not make large stocks of vaccine before your efficacy trial results came in. Because if it didn't work, you're left with large stocks of a very expensive vaccine on your hand that you have to kind of throw in the bin. Well, that makes no economic sense. You can't do that. So the government, and it's true in Europe as well, took on the financial risk and said, okay, look, we know this might not work. We think it will. We'll pay, get producing, fingers crossed. And that turned out to save many months. So we'd have got the efficacy trial results in December and only then started manufacturing, and we wouldn't be where we were today. So that was the one best decision Warp Speed made.
Okay. Do we know how long the vaccine will protect? Will it be like a flu shot where you have to take it once a year?
Well, we don't, because the one thing you can't buy is time. So the only way to determine events over a year is wait a year. And we haven't had that long. But you know, some vaccines literally last for life. I mean, measles, it's probably not going to be like that. It's possible we'll need a booster in a year. We really don't know. Now, you can study immune responses to infection in infected people, and it's now, 9 months since March, so there are now 8 to 9 months data starting to come in. The immune responses in many recovered patients, convalescent patients, are still pretty good at 6 to 9 months. Well, will they still be pretty good at a year? We'll know after a year. And after 2 years, we'll know after 2 years. So immunity wanes, but there is such a thing as immunological memory, and that's being measured now in the 6 to 8 month convalescent patients, and it's not bad. On the other hand, we do regularly get colds, year after year. You may not get the same cold virus every year. The different types of cold viruses, but certainly coronaviruses are circulating. There are 3 common strains of coronaviruses, and people get them. If you get a cold, you may have an adenovirus, you may have a coronavirus, you may have something else, it may not even be a cold. But coronaviruses' immunity doesn't last forever. But if you get a cold every year, you may not be getting the same virus over and over again.
So I do have a question. We have more deaths every day in the United States. 3,000 when I last checked 5 o'clock today in the United States. But worldwide, we have lots of deaths. France has a curfew of 6 p.m. for the whole country. So what made things get worse the last few months?
Lack of leadership, lack of discipline in the population, just devil-may-care attitude in too many parts of the country. The coronavirus isn't real. A lot of us privately call this the Trump pandemic, because Trump had a lot to do with by failure. His failure to do anything about it deserves the sobriquet the Trump pandemic. If he'd influenced his supporters to take this virus seriously and behave sensibly, not go to super spreading events, wear a mask, if we'd had a longer lockdown in March and April, whatever the economic pain, we never burnt the initial wave out. Europe had a much quieter period over the summer. Coronaviruses don't spread as well in the summer. It's a seasonal viruses. So we're always going to see a reduction in the summer and then a resurgence in the winter. That's what coronaviruses do, we've learned. But in the States, there were really high infection rates in the South. In places like Arizona and Florida and Texas, which are pretty damn hot in August and July and August. And that's due to complete lack of discipline and in the population, the refusal to behave as this is a serious pathogen. And it's a shocking lack of leadership.
But it's also it's also very bad in Europe too.
Absolutely, but in Europe, but again, different countries have different patterns.
Okay.
It peaked in March and April. It went down pretty low levels. In the UK, they got to a period in the middle of the summer where literally nobody died of coronavirus in the UK for a few days. Then there were 1 or 2 and so on. And then when we got to cold weather again, it sprang up again, which it was always likely. But here in the US, it sprang up from a very high baseline. We never got below about 40,000 infections per day.
Okay, so now we got a question. What is the risk of taking a vaccine? Is it reasonable to think the risk of coronavirus is less than the risk of the vaccine?
The risk of a vaccine is vastly, vastly, vastly less. People die of coronaviruses. They're not dying of vaccines. These allergic reactions have got a bit of coverage. They're 1 in 100,000 to 1 in 200,000 events. And the people who have them, they're equivalent to a bad reaction to a bee sting. Well, I'd take that chance.
Okay. Also, there's a question just I'm asking, is that we've been told that the British strain is much more infectious, like 70% more infectious. What is that based on? Is it true?
Yeah, it's hard to put an exact number on it. It just takes time to get that kind of information, but it is significantly more infectious, more transmissible. And you can assess this by looking at the percentage of the new infections in the UK, where they're good at this, that are caused by the original strain versus the new one. And you can see one drowning out the other over time, and then you get a measurement. That's what happened with the D614G virus I mentioned during the spring and into the summer.
Okay, this is notes to my audience. I'm not going to take questions about conspiracy theories, about it being man-made, things like that. So, and if you don't put your name on it, I'm not revealing people's names, but when someone says anonymous and asking whether viruses were man-made, I'm just not going to dignify those questions. What is your impression of the recent preprint from Dr. Penny Moore's lab regarding neutralizing antibody escape by the South African SAR2 variant?
Yeah, I mean, Penny's an old friend. She's also a veteran HIV researcher.
Where is she? Where is she?
She's in South Africa.
Okay.
Yeah, no relation, by the way.
Okay.
Yeah, I mean, people in the HIV field started calling her my wife, which was just an in-joke within a month or so. No, I referred to that paper earlier in one of the monologues I just gave. It's one of the papers. The other one was from a group at the Rockefeller just across the street from here that started to look at the South African variant and its sensitivity to neutralizing antibodies. Penny's team have not yet published their work on looking at vaccine sera, but they're doing that work. It's just not finished. But they showed that the South African variant is highly resistant to convalescent plasma and to monoclonal antibodies of the type that are now approved for use in therapy, the Regeneron and the Lilly mAbs. They didn't use the Regeneron mAbs, but they're probably going to behave the same. And these were taken out by the South African variant. So again, if that variant spreads widely in the States, those monoclonals are going to be pretty useless.
Here's a basic question. Why does one vaccine need to be kept at super freezing temperatures, but the other one doesn't?
Yeah, it's down to the fine details of the composition. I mentioned that the RNA vaccines have a lipid fat shell, which encapsulates the RNA in the middle of these little balls of fat. And one company in a rush did a better job than the other. And it's the details of propriety, although the Moderna, full composition of Moderna has been published in the New York Times, so it's not exactly a secret. But it'll relate to some subtle difference in the composition of the fat shell. And it means that one can survive. The Moderna one is the more stable, but it still needs freezing. You know, it still needs to be shipped at -20. The Pfizer is -70, which is pretty damn chilly. I mean, we have -70 freezers in the lab, and you don't want to put your hands in them. So, but the newer vaccines that are coming along, the Johnson & Johnson in trials, the AstraZeneca in trials, and Novavax, they're all stable at 4 degrees under a standard refrigerated condition. So they can be shipped on ice.
Okay, someone asked the question, is there any institution maintaining a centralized database of vaccinations and resulting experience similar to the data about infections that Johns Hopkins University maintains?
Well, the New York Times has a pretty good tracker site.
Right.
I don't think it's an official tracker site, but it gets its information from somewhere, presumably by collating the states. So states collate their data and the Times, and I'm not picking out the Times. I know the Times is there, but it's probably in other media outlets as well. How it's done in other countries, I wouldn't know. I wouldn't know. I could Google around and find it, but if you ask me what the vaccination rate was in Switzerland, I have to go and figure out how to find out.
So we know some countries have done very good jobs, like New Zealand, and in terms of containing the virus, and Israel in terms of getting out the vaccine. I know I have family in Israel, and my cousin said everyone's in an HMO and they get text messages. It's your turn to get the vaccine on this day and whatever. And they vaccinated everyone over the age of 60 who wanted it. Now they're going down to the 50s below, and it's a small country, but still, it's a better approach than what we have.
Yeah, I mean, it helps that it's a smaller country and it's centrally organized. You don't have 50 states, you have one supervising authority, and all of that will help. So, sure. And New Zealand, I don't know what the vaccination status of New Zealand is, but you know, it's an island. That helped. It's quite remote. That helped. There are only a limited number of airports. That helped. And they acted early and decisively at government level under a very capable national leader, Julia Ahern, I think her name is. They did a great job.
Yeah, Stephen Colbert went there and spent some time with her. It was a lot of fun. So someone said if you were to take the Moderna vaccine, would taking the Pfizer vaccine also increase one's protection?
Yeah, it's not recommended. I mean, the FDA doesn't recommend it, but in practical terms, that these two mRNA vaccines are so similar that it really would be a distinction without a difference. I'm not recommending it because it's not FDA approved, but I certainly wouldn't be freaked out if that happened.
So let's say in 3 weeks, I can't get the Pfizer vaccine, could I take the Moderna vaccine?
I honestly doubt that you would be given it because it would be contrary to approved procedures and the
Okay.
charge wouldn't allow it. And the hospital you go to probably doesn't have both in stock.
Right. Yeah. So someone said, is it a bad idea to take ibuprofen when you have side effects from the vaccine? Like, I don't see why it would.
I don't see why. I don't take many drugs, but if I'm after my cricket matches in the summer, I take industrial doses of ibuprofen because it's the only thing that keeps me going.
Okay. So here's a basic question. How do we talk to family and friends about the safety of vaccines and encourage them to take their shots? I just heard a statistic today that 65% of Americans now want the vaccine as opposed to a year ago when 40%, 45%. The numbers are going up.
Increasing. I saw that same story, and that's improved since the election when vaccine confidence was badly politicized. I mean, everything is badly politicized, but it was affecting vaccine hesitancy. So yeah, it's increasing. There's decades of good experience with vaccines. It's the technology that's, other than clean water, it's probably saved more human lives than any other medical intervention, if you can include clean water as a medical intervention. Vaccine side effects happen, but they're rare.
They also said that having people, like having the politicians take it, like Mike Pence took it publicly, Biden took it publicly, that helped. But I saw an article that Elvis was asked to take the smallpox vaccine after a performance on the Ed Sullivan Show, and he did. There's a picture of the young Elvis, taking the vaccine, and that drove up that people trusted. I mean, Elvis is not a scientist, but people,
Well, as Elvis is reputed to still be alive in some circles, we can perhaps recruit him for this one. No, but cultural icons are important. I mean, if you're dealing with the Black community, getting leading Black baseball players, sports stars, rap artists, people respond to people that they know and trust. So, and it's still a huge problem getting vaccine rollout in Black and Latinx communities. I mean, the distrust is greatest there than anywhere else for historic reasons. And even healthcare workers, Black and Latinx healthcare workers are refusing the vaccine at higher rates than white majority counterparts. It's a real problem, but cultural icons make a difference.
What do you think of the approach the U.S. Army is taking on their vaccine? Is it supposed to work on all coronaviruses? So does that mean it could work on any mutation? I'm not aware of the U.S. Army vaccine.
I'm not aware of the U.S. Army vaccine. There's no separate vaccine the U.S. Army takes. They have access to the same vaccines as the rest of the people.
Okay. One person said, I'm very worried about the long-term effects of the vaccine. Well, the short-term effects of coronavirus is death.
Yeah, that's one good answer. I mean, look, you cannot know long-term effects for the long term, but people have been taking flu vaccines for long periods of time. People have been taking measles vaccines for long periods of time. There's a long history of experience with vaccines, and there's a perception that the coronavirus vaccines are new? Well, as I said right at the start, they're new to an extent, but they use established technology. And even the mRNAs are not brand new. They're newer, but they're not brand new. So I understand that, the argument that anything new you should be nervous about, but the risks of getting coronavirus, especially for older people, are pretty damn significant.
So here's kind of a related question. I understand that there's a major effort to develop vaccines specifically so they're affordable for low and middle income countries. Are these, I guess they're speaking about the AstraZeneca vaccine.
Yeah.
Are these vaccines different than the ones we're getting here? I think India just started inoculating people with that vaccine.
Right. Well, it's going to be difficult to get the mRNA vaccines distributed in resource-poor countries. I mean, it's difficult enough to ship things around in purpose-built -70 freezers. Try doing that in Central Africa. So there are going to be real logistical issues. As I said earlier, the J&J, the AstraZeneca, the Novavax vaccines, which are the next leading ones in the USA, they're all shippable at 4 degrees, which is much more manageable. The Chinese, the Russians, and recently the Indians have done a lot of work with what we would consider pretty antiquated technology, inactivated virus vaccines. And they're also going to be shippable at 4 degrees. They're not looking to be as effective as the Moderna and Pfizer vaccines, but they do have significant efficacy. You can argue about the numbers. The Russians and the Chinese are not being terribly transparent. There's some controversy about it all. But the Russians and Chinese in particular are using their vaccine programs as soft diplomacy, as ways to gain influence in other countries by providing them with vaccines, which America under Trump and America First just refused to do. So America is losing international diplomacy and world power and world influence by its current attitude, whereas the Chinese and Russians are really carrying it.
So let me ask a question. So let's say there were not the Moderna and Pfizer vaccines. If everyone got the AstraZeneca vaccine, that would still help.
Yeah, I mean, the AstraZeneca vaccine isn't approved yet in the USA. It's approved in the UK. The UK trials were, somewhat messy. They were dangerously messy, but they were ambiguous results, and they did a lot of chop and changing. They were not conducted to FDA standards, and the FDA is not accepting the British data. It has its own, the company has its own phase 3 trial in the USA to a standard design to FDA standards, and it should report within the next several weeks. And if those results are positive at a significant level and it's a clean trial, you can expect the FDA to do what it did for Moderna and Pfizer. Johnson & Johnson results, J&J, will probably be in, within a week or two. I mean, it's sort of one of those any day now scenarios. And they have 2 trials. One is 1 dose and the other is 2 dose. And the 1 dose trial will report first. The Novavax trial in the USA just started a few weeks ago, but they have a phase 3 trial in the UK of the same design that could report within days to weeks. And that might be of the appropriate standard for the FDA to consider approval based on that.
Well, there are certainly advantages to having a 1-dose vaccine.
Yeah, halves the number of doses. Makes it logistically simple. So the dilemma will come if the 1-dose vaccines are much less effective. But let's cross that bridge when we come to it.
Okay. So here's a question. Vaccines are only approved for people 16 and above.
Sure.
Will there be a modified vaccine for children? And why hasn't there been any talk about this age group? Should this vaccine be added to a child's regular vaccination schedule, or should it be taken separately?
Well, in time, yeah. The FDA standards, and appropriately so, is that you test vaccines in adults before you test them in children. And I think we'll all understand why that is. I mean, safety concerns, we want to protect the kids better than adults have any unforeseen side effects than children do. So that's normal. But there's no intention to exclude children. It just means the trials in children haven't had time to get going yet. Also, children are much less susceptible to the disease-causing consequences of this virus. We all know that. It doesn't mean they're immune to it. They contract it and they can very few exceptions. There are exceptions, but they're fortunately rare. Children do not get seriously ill and die, so it's not the higher priority compared to getting it into older people. It's all a question of time and priorities.
Okay. Do people who get the vaccine, will they still need COVID tests before visiting their family or traveling? Exactly
Well,
what?
Yeah, this again is going to shake out over time. What we know is that these vaccines prevent disease. That's what the trials show. So if you get these vaccines, you have a 95% chance of not getting disease, not being hospitalized, not dying. The trials were not designed to look at whether you get infected, but without symptoms. And a number of people, it's well known, some people, especially younger ones, don't even know they've had coronavirus. So that's called asymptomatic infection. And it was not tested whether asymptomatic infection is prevented. Now, a lot of people in the field think that it probably does work like that, but we don't have the data. So there is this risk that you're still capable of getting infected and not knowing it, but being contagious for others. And this again takes time to become clear. We all want these answers, but you can't buy time. So the prudent thing to do at the moment is not change your behavior. And don't throw away your masks. Don't, if you start throwing away your masks and walking around New York City and saying, look, I'm not a mask refusenik, I'm a vaccinated person, you're going to run into problems anyway. Also, it takes 2 weeks after the second dose before you're fully protected. Almost nobody is there yet. In fact, probably nobody is there yet.
No.
So it just takes time, and everyone, including all of us, want to get back to normal, and it just takes time to answer these questions. It's just we have to be patient about it and continue to be sensible.
Can you please explain how a virus becomes more transmissible?
Well, there are 2 ways it can happen. The virus infects cells because its spike protein latches onto a protein on the surface of cells called ACE2. And if you increase the binding affinity of the spike protein for ACE2, then that will increase the rate of infection. So anything that increases the performance of the spike protein will increase infection and increase the probability. The other mechanism is that the infected person can produce more virus particles in nose and throat and simply cough and splutter and sneeze out more virus particles on any one sneeze or cough. So the more you eject, the more likely you are to infect someone who's nearby. So both of these mechanisms are relevant, and it's not completely clear how each of these variants acts at the moment.
So now that the highly transmissible variants are around, do unvaccinated people need to take additional precautions to protect themselves, such as double masking or additional social distancing?
Well, look, the new variants haven't grown a pair of scissors. They don't cut through masks. They don't have spring heels grown out of nowhere, and they can't, they can't bounce 20 feet. I mean, yeah, they can be ejected more of them, but they're still fundamentally the same virus. So you take the same precautions and it's not going to be a problem. It's only when you don't take precautions and put yourself at risk that you increase your probability of getting infected. I've read about double masking. I haven't read enough about it. I don't think there's enough information about it to know whether it would be more effective. I'm still wearing my standard one mask, and I don't intend to change at the moment.
Okay, so I have friends who are buying KN95 masks, silicone enhanced vaccine masks that are made in Israel. I don't think any of this technology we know really works.
Well, to a certain extent, it's whatever floats your boat. If you think you want to wear them, if you think it works for you and it doesn't do you any harm, then there's nothing wrong with doing things like that. I personally don't consider it necessary, but I'm not going to tell someone else what type of mask, or if you want to go out with a dustbin over your head with ice slits cut in it. Whatever works for you within reason, as long as you use common sense and appropriate precautions. But there's a certain amount of individual choice, as long as that individual choice doesn't involve not wearing a mask at all.
So once we're vaccinated, will we still have to behave according to all the precautions? And if so, how long?
Well,
who knows? Yeah.
As I just said, for the foreseeable future, until we learn more, behave exactly the same. You know, we all hope that by the summer, our lives will come back to normal, but no one knows for sure. I mean, you know, we all want crystal balls. I just had my birthday. I didn't get a crystal ball. It's just.
I'm so sorry. I would have sent you one.
No, I mean, it's just so frustrating because we all ask ourselves exactly the same questions we're being asked today, and we all want to know the answers. And I don't know is often the only answer we can give.
Okay. So you don't have to answer this. What is your assessment of the individuals in the Biden administration's coronavirus task force? New names that make you especially hopeful and new names that make you worry.
Oh, they're all very impressive. We don't have Scott Atlas around anymore, for one thing. I mean, that in itself is a bonus. He was an absolute disaster. Look, they're all good, seasoned professionals. I only know some of them by indirect contact. We still have Tony Fauci around, of course, who has been amazingly good in all of this. So that's not changed. The new CDC director looks outstanding. The head of the vaccine task force, David Kessler, he's very experienced, ex-FDA director. They're all top quality people. So I expect to see an increased ability level and just better coordination among the different arms of the federal government.
So someone would like you to stand up and say, what does the last line in your shirt say? We cannot see it in the video.
Oh, sorry. On the advice of my attorney, my shirt has no comment at this time.
Okay.
Look, it's pandemic. I didn't have any formal Zoom interviews today. I don't wear this in a normal year, but we've been slobbing around all year because we can. It's a medical school. It's not a bank.
So, okay, so we answered that question. So I like to ask people what they do. So have you done indoor dining?
No.
Okay.
No.
Have you done outdoor dining?
Yeah, once. I'm not a big going to restaurants type of guy.
Okay.
I wouldn't, we don't routinely in my family go to restaurants. On a normal year, it has to be a special occasion. If you're out with friends, of course, you go to a restaurant, you're with a group of friends. My cricket club had a couple of dinners in the summer outdoors, which we did. I had dinner outdoors, I don't know, October in New York City, but it's not my shtick anyway, very often.
Okay.
And in January in New York, outdoor dining, kind of not,
I had out there dining last week, and the problem is the seats are very cold.
Yeah.
And the food gets cold very quickly. So I think I'm gonna wait.
Well, by the time you go to tomato soup, it's gazpacho. Yeah.
Yes. Do you go to museums because they're open in New York?
I haven't been.
Would you go?
Yeah, I just haven't. But I did the museums when I first came to New York City in 20, 30 years ago, and other times since. I don't have a big incentive to go. But yeah, I would go around an open space like that. Yeah.
Okay. So, I know you live and work very, close by. I mean, do you have a pod with your family?
Well, two kids, adult kids, live in New York City. Well, actually, our son's just moved out of town for a while with his girlfriend. But we saw our daughter yesterday and her fiance because it was my birthday, and they've been tested recently and they're fine. So yeah, but we don't do a lot of socializing.
So do you see them outside, or can they come in your house?
We let them in. They've been regularly tested.
Okay. Because I've talked about my daughter won't let me in the house. So, so what do you recommend to people about, one doctor said to me, now's the time not to let your guard down because we're so close to getting everyone vaccinated. And
Yeah, I mean, we're all fed up. We all have fatigue. We all just, every day is a blur. The only reason I know it's a weekend is because the New York Times is thicker. I mean, it's the point where it's just been there, seen it, worn the T-shirt. Where's my other T-shirt? I mean, it's just depressing. But infection rates are at an all-time high. We're at 200,000 infections and 3,000 to 4,000 deaths a day. This is at least, if not the peak of the pandemic, it's pretty close to it. So why give up now? I mean, why give up when it's worse? Then we have to gut this out. And yeah, the vaccines will make a difference over time. But again, we need time for that. So there's a balance between resurgent infections and gradually rolling out vaccine. Buy yourself more time. Don't do anything stupid at the moment.
okay, people do very stupid things though. So I have a question. Is herd immunity possible without a vaccine?
Well, not without, a million to 2 million dead Americans. This was always the, choose word carefully.
Okay.
Only very few letters in it. That Atlas and Trump were, and some other enablers and this group of renegade scientists were promoting over the summer. And the Swedes messed around with this, and look what happened there. They had the worst pandemic in Scandinavia. You can get to herd immunity if you were going to sacrifice 1 to 2 million dead Americans to get there. Well, that's not a price most societies were willing to pay. So the answer is no, it's not a good idea. Vaccines should get us there, and estimates vary as to what the percentage of the population is, but if you include recovered people who probably have a third degree of immunity from reinfection plus vaccinated, you need to get a vaccination rate of about 60 to 70%, and maybe you add on 20% of the recovered. It's ballparks. I mean, nobody can give you a really precise number. The more contagious the virus, the more the herd immunity percentage goes up. But so, aiming at 70% is a reasonable number.
So can we compare this to the Spanish flu? Because that took 4 years to go away.
It did. People call it the 1918 pandemic, but it didn't really disappear until 1921. Although the worst was 1919, the winter of 1919. I'd read the John Barry Great Influenza book years ago, and it's been a New York Times bestseller again ever since. But I mean, in this pandemic, and I think 500,000 Americans were reported to have died in that. I think that's the right number. Well, we're now up to 400,000 in the coronavirus. The influenza pandemic killed 50 million worldwide. I mean, no one was counting. There weren't the internet. There wasn't that kind of record. But historic estimates suggest it's 50 million. Well, we're not there yet with the coronavirus. And again, in a lot of countries, is undercounting. So there are parallels, and but the difference is we will have a vaccine for the coronavirus. We didn't have one for the influenza pandemic. So that will probably mean that it will not last 3 years.
So one thing, when I spoke to Dr. Fauci on a JAMA call, I asked him, we've come to accept that 60,000 Americans die each year of flu. Should people have been wearing masks during flu season?
Well, in retrospect, I mean, it would have been a good idea, but it was not the cultural norm here. And changing cultural norms is remarkably difficult. And, of note is that there's been much, much fewer flu cases this winter because people are wearing masks. People are not getting flu. They're not getting bad colds because they're wearing masks. But, in Far East countries, mask wearing in the winter is normal. And, maybe we will adapt to that. I personally doubt it. I think there's just an acceptance that flu is one of those things in a typical year. It's, I don't know, I'm not a sociologist. It's hard to figure this out, but it's something to think about. It's food for thought.
Okay, so before we go, I just want to mention, so on next Wednesday, February 3rd, I'm going to be speaking to Dr. Mirella Salvatore. She's an infectious disease specialist at Weill Cornell Medical Center. On Thursday, February 11th, I'm going to be speaking to New York Times reporter Apurva Mandavalli. She's on the front page almost every day if there's a COVID story. And on Thursday, February 18th, I'm speaking to Dr. Mew Cervic, Infectious and Global Health Division, University of St. Andrews in Scotland. So that one will be during the day because of the 5 hours or 6 hour time difference. And so any last words of advice for us, Doctor?
Keep your guard up. You know, the British had a phrase in World War II, keep buggering on. It was just, look, life is grim, but it will get better. Just keep doing what you're doing. Stay safe, be well.
Okay, well, I think that's a good thing to end on. And I want to thank Dr. Moore for spending time with us tonight and answering a lot of the questions, and I think almost all of them. And for those who missed it, this will be on YouTube tomorrow. So thank you very much. Stay safe, and I'll remember your birthday next year and send you that crystal ball. Okay, take care.
So
Bye-bye.